Okay. Hello and welcome to TEDMED's live event focusing on the great challenges of coming to grips with the end-of-life care. I'm Lisa Fields and I'll be moderating today's discussion, which is going to run about an hour. This session is part of the Great Challenges program sponsored by the Robert Wood Johnson Foundation. The goal of the Great Challenges program is to look at 20 of the most complex problems in health and medicine, issues that can't be solved with a magic bullet or a one-shot cure or policy. Our mission is not to solve these issues, but to share ideas with many other disciplines to reach a better understanding of them than we had before. We'll be taking questions from viewers on Google Hangout and Facebook and, of course, Twitter. The Twitter is TEDMED, and then just tag your questions with hashtag Great Challenges, and then we'll try to get them in. As I mentioned before, I'm Lisa Fields, and TEDMED has invited me to moderate this event today. The reason they asked me to be one of your moderators is, as a teenager, my grandparents were kind of unusual, and they talked a lot about the living will even when we were teenagers. I've also done pastoral care as part of a team for many years, and then I was very fortunate to get involved in tweet chats on Twitter, and there's several of them. The tweet chats, conversations on Twitter that I've been involved with are Hospice and Palliative Care, Death with Dignity tweet chat, and Healthcare social media in Australia. So I've been fortunate enough to moderate and be an active community member there. So today we're going to highlight the great team of 6 experts that we've called the Great Challenge Team, and they're going to help us lead the discussion that we have today. The first person is Jenny Chin Hansen, and she is the recent past president of AARP and the current CEO of the American Geriatric Society, the nation's leading membership organization of geriatric healthcare professionals who share a mission is to improve the health, independence, and quality of life of older adults. Next on our panel is Paul Malley, and he's the president of Aging with Dignity, a national nonprofit organization that created and currently distributes the 5 Wishes Advance Directives, the most popular current used by Americans to make healthcare decisions before a serious illness. You currently have 18 million copies distributed around the world in 26 languages. Next, we have Dr. Richard Payne, MD. He is the professor of medicine and divinity at the Duke Divinity School, Duke University, and is internationally known as an expert in the areas of pain relief, palliative care, oncology, and neurology. As a physician caring for persons with neurological disease and cancer, he learned that he couldn't cure all of his patients. I learned that I still could be an effective healer if I was competent in providing system management, in communication with my patients, willing to be fully present in their illness journey. Bruce Jennings is the director of bioethics at the Center for Humans and Nature. He is also the senior advisor and fellow at the Hastings Center, where he served from 1991 through 1999 as the executive director. Both real-life experiences participating in the care of his patients and ethical theory drives his work on the fundamental importance of respecting the rights of patients, responding to the concerns of the families, and finding practical ways to improve decision-making and communication in the end-of-life care. Joan Teo, MD, is the professor of health service policy and practice and the associate director of the Center for Gerontology and Healthcare Research. As a daughter, health services researcher, hospice medical director, and internist certified in geriatrics and palliative medicine, she has advocated for the medical care to be with patients and family centered, creating the Family Evaluation of Hospice Care Survey and focusing her research on the use of feeding tubes in persons with advanced dementia. Catherine Tucker, JD, is the Director of Legal Affairs for Compassion and Choices. She is recognized as a national leader in spearheading creative and effective efforts to promote and improve pain care for seriously ill and dying patients. Most notably, Ms. Turner served as the lead counsel representing patients and physicians in 2 landmark federal cases decided in the U.S. Supreme Court, asserting that mentally competent, terminally ill patients have a constitutional right to choose a humane death with physician's assistance. Welcome, everyone. We're all so excited for you to be here. This is a wonderful interdisciplinary community that we've brought together. So once again, welcome. I wanted to kick off with a pretty impressive and almost daunting statistic. In 2010, Medicare paid $55 billion for doctors and hospital bills during the last 2 months of a patient's life. And so that's part of why we're here today, is to talk about those issues. So the first question that came in, and this question came in from a Facebook person, was they asked for us, the question is, for Chirda data, how can we make discussing and deciding end-of-life questions calmly with our loved ones long before the need arises? Maybe it could be a part of responsible living, like buying health insurance or making a will. So I wanted to know, Bruce Jennings, would you like to handle that question for us today?
Well, I'm not sure I can handle all of the question, but it is absolutely true that the way we have our end-of-life care system, it's very important for people to speak with their loved ones and their families ahead of time. Advance planning and treatment planning are very important aspects of ensuring that the kind of care you receive at the end of your life will be beneficial for you and will respect your wishes and your dignity. The fact of the matter is we have medical technology today that can save some people who can be saved, but sometimes it's actually harmful or undermines people's dignity and quality of life to use this medical technology. Therefore, it's very important that individuals direct their care, and if they lose the capacity to do so, their loved ones who will be making decisions for them need to know what their wishes and values are. So the conversations that we're talking about, the advanced conversations, become key, because otherwise you put your family in a position of extreme stress and uncertainty because they have to make decisions for you without your guidance, and it's very, very hard for them to do that often. So unfortunately, these are hard conversations to have ahead of time, and sometimes by the time you're in the hospital or you're very ill, you may really not be able to have those conversations at that time. So having them in advance is the best way to proceed. And families need to cooperate. It's hard to become comfortable with this sometimes. Some families are very comfortable with this kind of conversation. Others are not. There are outside resources to help guide some of these discussions and make the questions a little bit easier to deal with. And friends can sometimes help. Clergy can sometimes be helpful here. And of course, your family physician, perhaps, or other healthcare professionals. It's not easy, but it is very important.
So it sounds like you're talking about a team coming together would be most helpful.
Well, I think it is best in general if you don't just talk to one family member, but you try to get as many of your family members together or your loved ones as possible. Sometimes it's easier to talk to them one at a time, I know, but it's also helpful, I think, for family dynamics if perhaps you can have a group conversation at some point. I've heard that sometimes families do this at the Thanksgiving dinner table, for example.
Right. Okay. Paul Malley, would you like to also address this question about discussing and deciding the end-of-life issues, if you have any tools for doing that before before it becomes an emergency?
Absolutely. And I think you hit on one of the biggest points. Don't wait until it's a crisis or an emergency. The thing that we've heard so often in the past 10 to 12 years is that so often people don't feel like we're qualified to have this conversation, right? I'm not a doctor, I'm not a lawyer. How do I start talking about these questions with my parents or my grandparents? And so I think the important thing for everyone to know is there's not some magic qualification that you have to start this conversation. If you're sitting here listening to this message and you have parents who are in their 60s or 70s or grandparents, or if you're in your 20s and 30s and you want to talk to your spouse about it, don't wait for a doctor to bring it up. Start the conversation in your family. And Lisa, you mentioned even your church had talked about this, and that's so important. Working with our faith-based communities and employers too, that give out resources. Five Wishes is one of them. There are others. Everyone should use whatever works best for them. But they give out these resources along with employee benefits information like life insurance and health insurance and retirement planning. One of the things that's coming up is National Healthcare Decisions Day. It's on April 16th, day after tax day, just so you can't forget it. But it's an excuse. It's a way for you to say, hey, mom or dad, or to my husband or my wife, let's talk about this. It's something to talk about. The one last thing I'll mention too is that if you're thinking about coordinating something within a community, even beyond your family, say for a civic club or a church, you don't have to do that alone either. One of the best resources in the community are the hospices that are out there that will send someone out and do a presentation and talk with your community. So there's nothing magical that you have to possess to start this off.
Okay. I would love to also give Dr. Payne an opportunity to talk about this question.
Well, yeah, Lisa, I was thinking that, there's such a understandable ambivalence that we all have as humans to talk about and confront our mortality. So it doesn't surprise me that we have difficulty with these conversations. I think one way to help kind of normalize these within family life is to encourage telling of stories about that kind of help people reflect on their values, and then use that as a basis to move into kind of some more specifics, issues around completing documents and stuff, but to encourage telling stories and to encourage activities that talk about what it means to be ill in community is important. I think that, for example, for people who are in faith communities, it would be quite natural for churches, synagogues, parishes to talk about this. I know Paul is on the line here. I think I know of a church in Chicago in which the pastor role modeled for the whole congregation doing a Five Wishes Saturday. It's a very, very powerful way, and of course that doesn't occur out of context. It occurred in a context of encouraging people to talk about what it means to be ill and what it means for other community. The other thing I would say is that figure, that staggering figure of what Medicare spends in life, it is truly impressive. But I think we also have to realize that there's a reason it's the last few months of your life, because you're sick. And now, so the question becomes, of course, how much of that money is well spent and how much is not well spent. And that's where we need to focus. One way we will, you kind of get to know that, and one way I think we'll spend money better is if we encourage people to talk more about their preferences and goals and with their healthcare providers.
When they're still able to do so.
Yes.
Okay.
Yeah, Lisa, if I could just jump in real quickly, I think it is true that Five Wishes has a lot of their documents out there. Compassion and Choices offers a different approach to end-of-life care planning that is not faith-based. And so for listeners who may not want a faith-based approach to end-of-life care planning, they might like to know about the resources available through Compassion and Choices. One of the things that's so important, because the decisions about end-of-life care will be intensely personal, is to be sure that the documents you're signing, the provider that you're working with, knows what your views are and whether they are influenced by particular religious views or not. You may, want to ensure that your provider is willing to respect your wishes. And so, for example, some providers have religious restrictions on the kind of care they're allowed to provide patients or are willing to provide patients. So it's really important to talk with your provider early about whether you shared those views, whether those limitations are ones you're comfortable with, and if not, find a provider who you're confident can provide the care that you want, because again, it's all about empowering patients with choices that reflect their values and beliefs.
And Catherine, aren't some hospitals also, they have, it's not just your physician, but it also may be the policies and procedures of a hospital.
Right.
Is that true?
Yes. The Catholic healthcare facilities, which do provide a lot of the medical care in the United States, are bound by a set of directives called the Ethical and Religious Directives for Healthcare. Those govern healthcare in all Catholic facilities. And many people don't know that at Catholic healthcare facilities, for example, continued tube feeding is something that those directives require. Now, some patients may not want tube feeding at a certain point in their care, and they may want to be confident that if that point arrives, they can direct the withdrawal of the tube feeding. So that's so important to know.
Thank you so much. And Joan, you've made a great point. Did you want to talk about not making a plan?
Sure. I think I just want to raise 2 points. One point is if you don't make a plan, you've made a decision, because the default it will be that you will receive aggressive life-sustaining treatment. A second point I think it's really important to make here is you start early, but you have to always continue to discuss what your plans are and your goals of care. Often early in the course of a serious illness, probably you want to just, first of all, name a proxy or a surrogate decision maker. As you go on this journey of this serious illness, some people will reach a point where it's very important for them to remain at home and no longer go to an acute care hospital. At that point, it's really important that you ask your healthcare providers to help you make a plan on how your wishes are going to be honored. And often, one way of making sure your wishes are going to be honored is to involve hospice.
Great. And Jenny, I'd love for you to jump in too.
Sure. Well, I think one of the things that is important to do is to start this far upstream in terms of, it was mentioned that Thanksgiving might be a good time in which to do this. However, sometimes that's such a tough time because there's so much activity going on, even though we're physically gathered. But there are situational opportunities when our parents, friends may pass away, and the opportunity to start that conversation and to pick up on Joan's comment that it's over time, because I think this is something that you don't have 1 or 2 conversations with and basically it's done. And I'm talking on the personal level. So the ability to talk about things when our neighbors pass away, who happen to be our parents, friends, the ability to talk about what that experience was like, and does our family member think that those persons' wishes were understood and known? So that's more social based and thinking about it much more personally with tools like Paul's with the 5 wishes. Right now, I think Ellen Goodman and some of her colleagues have also moved what's called the Conversation Project, which is kind of the concept of being around the kitchen table. So I think that's one thing. And then the other thing is relative to the workforce, especially in the American Geriatric Society. A lot of our members are really prepared and preparing to have that difficult conversation, because whether you're a physician, a nurse practitioner, a physician's assistant, or others, talking about people about this process is not something that is oftentimes taught in their education, nor are people guided to it. So it's a professional track and a personal track.
And would you agree sometimes that if there is a death of our parents, friends, or relatives at that age, if we bring it up, then many times they're almost relieved?
Yes. I think most of us who have some experience in this, the majority of people have thought about this themselves, but sometimes the opening isn't necessarily there. And so the opportunity to talk about something situational is oftentimes the leverage.
Okay. I really honor how the Great Challenges program allows us to have this be interactive. So this is a really good time to take some questions from some of our folks on Twitter and Facebook. So we have a question from James Spitka, I hope I pronounced his name right, on Twitter. And he said, some statistics say that hospice use has doubled from 2000 to 2009. What does this mean in the terms of keeping patients out of the hospital and incorporating better end-of-life planning? So,
if it's okay, could I take that question?
Please do. So,
as it happens, this session was scheduled 2 days after I had the privilege of having an article published in JAMA. And in that article, we looked at what happened in the healthcare utilization between 2000, 2005, and 2009. And I have to admit, the first time when I looked at this data, I had to have a good stiff scotch, because this wasn't what I expected.
So you were surprised?
It wasn't the data I wanted to see. Yeah. Basically we saw a 200% increase in the use of hospice, but also more use of the ICU in the last 30 days of life, more repeat hospitalizations, and more late transitions. And so one of our concerns now, while we have increased the access of hospice, it's coming much too late. Hospice is really, unfortunately, being an add-on to a very aggressive pattern of care. And my concern is these Medicare beneficiaries are not really benefiting from the full multidisciplinary team. What they're getting is expert symptom control. But to me, hospice is so much more than just expert symptom control. We have wonderful social workers. We have wonderful chaplains. And so, I think that's one of the reasons we chose to write this article, is to put this into the policy context and ask, how are we going to change this pattern of care? For me, personally, this pattern of first the ICU, a hospitalization, then referral to hospice in the last 3 days of life is only ethically defensible if this is what patients want. And I have a feeling what's happening is this don't ask, don't tell. When it looks like there's nothing else to do, all of a sudden we give patient choices.
And do you think some of this has to do too with people not really delving into what is quality of life? What do you want, to be going back and forth to so many different places, including ICU, which I don't think anybody really wants to die in ICU.
I think, when you go to an acute care hospital, I think the number one thing I tell everybody is to have an advocate. Have someone who can be there to ask the difficult questions, to advocate for you. When you have a serious illness, it can be really difficult to try to negotiate with a healthcare provider who has all the power. So for me, I think it's really important that part of your advanced care plan should be who is your advocate who's going to go with you and help you navigate through this very complex healthcare system we created.
Right. Thank you. Bruce, would you like to...
Yeah, that kind of gets us connected to the earlier question about the importance of planning and conversation, because I think people over the years have come to think of this as filling out a form, filling out an advance directive or a living will. And that's very unfortunate for two reasons, which we've now touched on. One is that you really do need to have ongoing conversation with your family and your physician and others, because filling out a form isn't enough. And you need to have your family understand what you want and feel empowered to speak for you and advocate for you and stay with you as you enter hospitals and other kinds of systems which have been designed to use medical technology and do aggressive treatment. They're not designed to do otherwise. And so, in a way, the challenge is that we need to help people navigate into the right kind of system, the right kind of institution. The second thing I would just like to add here is that I'm afraid we've done a disservice to the public in part when we've talked only about refusing things, as if, I want to say no to this, that, and the other.
Right.
And in fact, what the advanced planning is about is not simply saying no to something, but also saying yes to something else.
Okay.
And it really is the roadmap of You want to be in the palliative care, hospice, quality of life, dignity while you are dying kind of setting and system? Do you want to be in the high tech, let's take a winger and see if we can prolong your life, even though in fact you are near the end of your life and you have an incurable illness?
Lisa, may I?
Yes.
So I
Thank you, Dr. Payne.
I mean, I agree with you, Bruce, that we've so emphasized refuse. You have a right to refuse things, but we haven't emphasized what you should ask for. And of course, one of the problems is people don't know what to ask for. There's such massive ignorance about what palliative care and hospice can offer. And it's still the case in 2013 that most people see hospice as a place you go to die, and that they see now, and many people see palliative care as just another kind of form of hospice that may be done a little earlier, but still it's about dying. So, I think that there is a lot more that has to be done in terms of really having people understand that there are alternatives to having to go to an acute care setting to get some basic like symptoms, or even a short trial of fluids and antibiotics, if that were to be the case.
Okay.
We have to be much better about bringing services to people in their homes and communities.
Okay.
And
Catherine,
Lisa, go ahead. I was just going to add on to that, and I think it's a good segue too, that a lot of times we try to fit into end-of-life care, fit people's end-of-life care wishes into the box of the medical world. And we did that with advanced directives back 30 years ago, creating these documents that were quick and easy, sign at the bottom line, and sometimes there weren't even choices to be made. And so it did get that reputation of being the form that you fill out if you want to stop care.
Okay.
And I think that held people back. So I think the focus on saying, here's what you can do to care well for me, and to talk just not in terms about life support treatment, but about what you want your family to know and how comfortable you want to be, and love and forgiveness, and even spirituality. Catherine implied that 5 wishes might just be for people who are looking at it from a faith-based perspective. That's not really true. It does include information about, or a request to say, I want people to pray with me, or I want my religious beliefs to be considered. But that's there to be crossed out if people don't want that, or to say no.
Okay.
And that's the importance of customizing the intentions and the wishes down to what is going to happen at the bedside. That's where the rubber meets the road.
Okay. I'd like to give Catherine an opportunity, and then Jenny, and then I'm going to take another question from our folks on Twitter.
Thanks, Lisa. And I know the original question, really was related to why do people come into hospice so late? And I want to just share the information that something that's so interesting, which is in the states in this country which have expanded end-of-life choice to include the openly available option of aid in dying, hospice enrollment has skyrocketed, and those enrollments happen earlier. So if I could spend, I hope, in some of this conversation, we'll talk a little bit about what is the range of choices patients have at the end of life. And one of the choices that's increasingly widely available, and I think will continue to be more widely available, is the choice for aid in dying. And that refers to when a mentally competent, terminally ill patient asks the physician for a prescription for medication which the patient could self-administer to achieve a peaceful death. This choice allows patients who find themselves trapped in a dying process they find unbearable to be able to achieve a peaceful death. We know from more than 15 years of data in Oregon, where that's been an open practice with a lot of study, that practice is an important one. Relatively few patients choose it, but when it's available, it raises the floor for end-of-life care for all patients, because physicians take more training in how to treat pain and symptoms. They prescribe more pain medications for patients who need it, and they refer more often to hospice. And importantly, those hospice referrals happen earlier, and that's so important so the patient can get the full benefit. 97% of the patients in Oregon who chose aid in dying were enrolled in hospice. So that's just a really interesting bit of reality, and I think as aid in dying becomes more widely available, we will see it drive referrals to hospice up, and those will be earlier referrals.
Okay, thank you so much. Jenny, you wanted to jump in here.
Right. What I hope to share was framing it back out a little bit. We were talking about what happens in hospitals in our conversation with the family. But I wanted to make sure that we all knew that there are communities that are really working on this on a much larger collaborative level, so that it is actually kind of the hands of a community supporting this. I think that the Gunderson Health System, as well as a group in Minnesota that we heard at, a one-day summit we had for the Coalition to Transform Advanced Care, starts to show that there's a way that the whole community is aligned, not just the families, not just the hospitals, but also the clergy and the social network, the emergency network is connected, and the ability to have this be a normal part of the community. But it is a long-term effort of really diligence. Of this is something that happens over a course of years, if not more than a decade. But with that, the whole community has a clarity of value systems of honoring your choices, and it doesn't go to just this comment about withdrawal. It is just how do you want to live, and what is the quality of your life? And I think that Dr. Ira Byock from Dartmouth has really said, what's the best care possible? And it doesn't always mean what we sometimes found ourselves in is treating people intensely, as been mentioned before.
Okay. Here's one question, and you know what, we're halfway through, and I really want to be able to give other people opportunities that are they're just flooding our gates, which is really wonderful. So Bruce, I was wondering if you could handle this question. It says a big problem is when directives are not followed in an emergency situation, particularly if the medical team is not aware of his or her wishes. Would the medical health records help with this? And will we ever be able to make sure everybody's on the same page?
Well, of course, the emergency situation is inherently difficult because of the uncertainty involved. If you have and the time factor. So there isn't time often to talk to people, to call people in, to get a hold of them, and that kind of thing. However, I think that some important steps have recently been made to try to deal with this problem a little bit. Patients who are being transported by emergency medical services have often found that they were given treatment, including something very invasive like cardiopulmonary resuscitation, against their wishes, and found it very hard to control that or keep that from happening. Mm-hmm. Nowadays, in many states, there are new forms. They're called POLST or MOLST, physician orders about life-sustaining treatment, medical orders about life-sustaining treatment. And they have the advantage over advanced directives that patients make out, in the sense that they are recognizable, they're medical orders, and they can protect against unwanted interventions, even, I believe, in the emergency context, even the emergency situation. Others can correct me if they have more information about that. But so steps are trying to be taken to guard against that. I do think, in general, the problem of inappropriate decision-making and unwanted care is not primarily caused by things that happen in the emergency setting. I think we're dealing mainly, in the vast number of people, with things that take place in settings such as nursing homes and other settings of chronic illness and longer-term decision-making, where there is time to talk to people, and there is time to make these decisions in a more deliberate way. And we're not doing a great job, as Joan Tino's study indicates, we're not doing a great job in those sorts of settings either. So you can't really take the peculiarities of the emergency setting, lack of time, lack of information, life and death, immediacy. You can't really take those and say that's the real cause of our problem here. Our problem with end-of-life decision-making is much broader than that.
Okay. Dr. Payne, this question's for you. In what way is the sensitive nature of this topic, emotions, and the journey of the patient, how's that taught in medical school?
Well, very variably, but I think we're doing better these days. There's actually a whole kind of new movement and curriculum in medicine called narrative medicine, which teaches young doctors and older doctors to try to understand and to assess the story of the illness, the impact of the illness on the person, and so that's helpful. I think generally there is much more emphasis now on teaching doctors how better to communicate, to listen empathically to the story, and to try to really understand how the illness impacts the person, and what values that we should be eliciting to help the patient and family with medical decisions. So that's all improving on a slow trajectory.
Okay. Catherine, would you like to piggyback on this one?
Yeah, well, I was just going to say that with regard to patients' wishes not being honored, even when the patient has gone through the effort to make their wishes known, either directly or through a surrogate, we do know that many times those wishes aren't honored. And as a lawyer, I'm actually handling a number of these cases on my desk at any given time. And, you know, the problem, it was hoped that these POLST forms that do have various names, but they are physician orders for medical treatment, was going to help resolve that problem. You know, but sadly, I have a number of cases where there was a POLST and the POLST was ignored. I think what's so important is that we start holding providers who fail to honor the patient's wishes accountable, because there needs to be accountability when that happens. The second piece of that is, unbelievably and amazingly, when a patient is subjected to unwanted medical treatment, say an unwanted CPR or an unwanted intubation, the provider then turns around many times and bills the federal government for that unwanted medical care, and the federal government provides reimbursement because there's no mechanism currently for the federal government to notice that the treatment was inconsistent and in conflict with the patient wishes. So at Compassion and Choices, we're really working on bringing attention to that and making sure there is a mechanism so that before reimbursement is provided, that it's only provided when the care was consistent with the patient wishes. In existing law, it would be prohibited to reimburse for unwanted treatment, but there's not a mechanism that identifies that, and that's something that needs to be fixed.
Okay. Joan, you have a quick comment on that?
Sure. I actually would like to bring back on the accountability part. Right now we have public reporting called Hospital Compare, and I just want to point out that Hospital Compare has nothing about the dying. If you go to hospice, you're not part of Hospital Compare. If you go to a nursing home, you will not get information on terms of a survey where you tell about your experience. You will not be part of that. So right now we have set up a system for looking at the quality of hospital care that does not include people who are sick, going to a nursing home, or people who have died. So, you know, the accountability issue is even much more bigger, and we now need to really demand that hospitals are held accountable for shared decision making.
Okay, and you don't feel like they're doing that now?
I know it's not being done right now.
Okay, all right. Another question that we have is talking about death. We've already talked a little bit about this. It's hard for doctors and patients and families, but open communication is essential for good end-of-life care. What can be done to make those discussions about prognosis and care options more honest and productive when a patient is very close to death? Jenny, would you like to take this question, please?
Sure. Well, I think asking that at the very point of just as the person's dying is fraught with complexity. I mean, the ability, you asked Richard, as to how people are getting trained nowadays. Our ability to kind of take each component part of the touch to the person, starting with the person, and then also each one to be able to talk about it. I find a phrase that Dr. Ira Byock, I mentioned earlier, really useful is, asking, would you like the best care possible under these circumstances? So, and leaving it open so that you can talk about different interventions. It's not just about more, but to help the family come to some degree of acknowledging that this may be the time toward death, but how would you like to have your family member die in the most acceptable way? But it's a choice. It's not a telling to that allows some conversation.
Okay, we have some more questions coming in. Thank you. The next question is from Jenny from TEDMED, from Rose Romano. How do we care for older people who come into the system with no family help to help them navigate the care and services, and who would take care of these people? Bruce, Jenny, you know what, you want to handle? You want to take that question, then we'll go to Bruce.
Sure. The part that's starting to happen is that there are sometimes communities that are coming together. I mentioned what's happening in Minnesota as well as in Wisconsin. The ability to have identified support systems early of somebody who knows them. The other side of the care when people go home, right now many states have programs where they're in-home support services. Some states have more of this than others, but that's a whole different direction perhaps of conversation of building a network of support for people who have no other family members. That is definitely a major social need.
Bruce?
Well, yes, I think that so often we're talking about things that have one set of problems sort of very near the end of a person's life and the end of a chronic illness that will end their life on the one hand, and then further upstream earlier. And this question certainly applies to both things. We have a very serious problem in this country developing a good long-term care system, particularly in the face of our aging society. So many people, such a large number of people, are going to be extremely elderly and frail and have various kinds of needs of that sort. They outlive their family, they outlive their friends, mainly women as I understand it, but nevertheless. So that's a long-term care problem in itself. End of life time, you have a problem, I think, especially when an individual, because of their illness, because of the side effects of their illness, lose decision-making capacity. They aren't able to speak for themselves. And if they have no family, if they are unbefriended and alone, then our system is set up. I think someone earlier mentioned, Dr. Tino, I think, said, if you don't sort of have a plan that says what you want, the default is aggressive treatment. And that is a trap that people who are unbefriended and have lost decision-making capacity can fall into very often. It's not clear how we can deal with this because we don't know what who do we trust? Who do we trust to make decisions for them? We trust families often, and we certainly trust people that an individual has named when they still have capacity to name someone. But if you take away those dimensions of it, the problem of trust looms very large, I think, and it's a real problem for public policy and for ethics. New York State is a state that recently, a couple of years ago, passed a law that has provisions for decision-making, end-of-life care decision-making in terms of unbefriended patients, isolated patients. And it puts it, of course, in the hands of the physicians and the hospital or nursing home ethics committee and so forth, and it tries to set out careful criteria so that these people are not simply neglected. Sometimes foregoing end-of-life medical technology is a very good and wanted thing. Sometimes, however, it's not appropriate and it's a sign of rejection and neglect. we have to figure out how to tell the difference, and we have to protect vulnerable people from neglect and discrimination in that way also. It's a part of the problem we have on our hands.
And families live so far away many times. They want to be involved, but they may not live within a geographic area where they could help. Richard, you wanted to say something, Dr. Payne?
Well, there are some innovations here for people coming into acute care settings who don't have family support or who just are overwhelmed by the system. Borrowing from other areas of healthcare, there are programs that are training community-based folks as navigators to actually help in an ombudsman role, but who have real knowledge of the system to help patients and families with these decisions. It's also, too, not clear to most people that when you get into hospice programs and palliative care programs, there's a whole array of people who are community-oriented, community people who are volunteering in those programs who can be of assistance in aiding people with, or just being a presence there. So that there are those kinds of more informal psychosocial supports that can be valuable to people.
Okay. I'm looking for some more questions coming in. Jenny, did you want to say something?
No, other than no, I can say something very short, and that is the fact that it may end up needing to develop new models of how small communities come together, and this is where tight-knit communities such as some faith-based communities that can develop amongst themselves, perhaps a way that's both transparent as well as really thinking about some of their particular members, knowing that they're alone, and to begin to plan for that in advance.
Okay.
And Lisa, if I could just make one quick addition. For so many of us working in this, it's a personal story that brought us to the mission. And I'm not going to share my whole one, but mine was sitting at the bedside of my grandparents and being with them in nursing homes and hospitals. And I saw that they got better care when I was there fighting for them on their behalf. And now, as you know, we've got this wave of baby boomers coming and aging. This will be the biggest issue of my generation and for my children in how we respond to that. As Richard mentioned, the navigators are a growing sector in healthcare. Also, professional patient advocates to walk alongside someone with it to navigate the health system. But not everyone is going to be able to afford that. And as Jenny said, that focus on the community-based responses. We have a program, Hope Today, that works in the rural North Florida counties that fills in the gaps of what happens when somebody's just discharged from a hospital without any support and without any family there. This will be a huge issue and a great opportunity for us to respond as a society.
Okay.
Yeah, I'd love to jump in, Lisa, if I could, just real quickly picking up on what Paul said about the reality of the aging baby boomers. Boomers are known for wanting to have it their way. And I think what we're going to see is as boomers confront their own terminal illnesses, there's going to be a tremendous, and we already see it, a tremendous upswell of patient-driven advocacy toward expanding end-of-life choice. And I think it's really a good thing because, of course, we want patients to be able to make the choice that is consistent with their values and beliefs. So I think, you know, so many patients don't know that they have a lot of choices already. As they approach death, they can choose to deactivate a cardiac device, to withdraw a ventilator, to forego food and fluid. They can choose palliative sedation, and ask for aid in dying. There is an array of choices, but people don't know about it. So there's a huge public and professional education task ahead of us of making sure patients know what these choices are, that they are empowered to choose them, and to be able to ensure that those wishes are respected. So for patients and families interested in that, Compassion and Choices is a great resource, and we really invite people to learn more about us and get on our website and get information and be informed consumers.
Okay. One of the questions I wanted to talk about real quickly was Dr. Ken Murray wrote a piece that almost went viral, How Do Doctors Die? And he said, doctors don't overtreat themselves. They see the consequences. Are we overtreating patients who have a terminal diagnosis? Are we overtreating those people? Joan?
Yeah, I think if you take a look at what's happened between 2000 and 2009, the pattern is more ICU use, more recurrent healthcare transitions. And I think what we've done so well is we've put forward an agenda on cost containment, but we created silos in our healthcare system, and unfortunately patients get passed around like a hot potato from one institution to another. And we need to really change the system back to one built around the patient rather than built around the institution. And I think to do so, we're going to have to bundle payments.
Thank you. Jenny, I want to get some more questions in here, but you were talking about a cultural perspective. Can you speak to that, please?
Yeah, you know, it connects to the community comment, and sometimes the individualism that we do have kind of as a central tenet in our system has to be put in context with families of sometimes different deep cultural backgrounds that are not consistent with, quote, the Western model. And it's something that I just think that all of us have to consider, because it oftentimes is a group decision-making process or a delegated in a different way model, just for us to be aware of.
Dr. Payne, is that currently happening in medical schools?
I take your question to mean, are we teaching young doctors to try to understand that there are around the ethical principle of autonomy?
Or maybe a cultural perspective?
Yeah.
Different cultures?
Sure. That of course, how one's preferences and values are often very determined by cultural perspectives and values. So we have to have healthcare providers of all stripes, not just doctors, but nurses, social workers, psychologists, to be really understanding that people come to making choices in this very vulnerable period of their life in very, very different ways, and not always out of a strict sense of this is my own personal decision, and my greatest value is to exercise my own personal autonomy.
Thank you.
People choose other modes of decision making.
Okay. The next question is from Facebook. Why isn't there more follow-up with families who have died, both as case studies and to promote them to start their own discussions? And so that seems kind of like a natural question for you, Paul.
Sure. Well, and I think
I got confused. Bruce?
I'm sorry?
Go ahead. I'm sorry. Paul.
Well,
my mistake.
I'll just add that I think there are some of these follow-back studies that look, and perhaps Joan, I think, may have done some of them, that look at family responses after someone has died. And that is one of the truest measures. When we think about end-of-life care, it's important that we not just think about the person who is sick, but that we think about their caregivers. One person may have a network of 10 caregivers, some of them sons or daughters or neighbors or friends that are caring for them. So we need to think about not only that experience for the patient, but for the caregivers, the family caregivers and the healthcare providers.
I think there was an article in the New York Times talking about caregivers having post-traumatic stress disorder.
With making that decision.
Yeah.
Yeah, actually, that's exactly what I wanted to pop in and talk about, is that we haven't really quantified what is the impact on family caregivers on a bad dying experience. We know that post-traumatic stress disorders are actually more common than we think, but also you have to realize this leads to lost days and works and has a huge economic consequences to our healthcare system. So I think we really need to look at how can hospitals, nursing homes, and all parts of our healthcare institutions help refer patients to bereavement services to make sure they get the appropriate emotional support prior to the patient's death and after the patient's death.
Okay, thank you. You know what? I can't believe it, but our time is just about up. I could stay with you all, and I know that all the people on Facebook and Twitter and Google+, I apologize I couldn't get to all of your questions. But I wanted to thank all of our team members who generously participated today, and thanks to everybody in the TEDMED community who's watched and sent questions. As I mentioned, this dialogue is going to continue on the TEDMED.com, and you also can post comments and questions on the TEDMED Facebook page, and we welcome everyone's input. And that's a really nice way to continue the conversation, especially for those people who might not have been able to answer those questions. And so I wanted to invite everybody to join us for a live event discussing the impact of poverty on health, which will be Thursday, February the 14th at 1 p.m. Eastern Standard Time, and provide medical communication on that same day, another one, at 3:30 to 4:30. Finally, we wanted to thank Robert Wood Johnson Foundation, the sponsor of the Great Challenges program. We couldn't do this without them. I also personally want to thank all the people who are behind the scenes doing the TEDMED Challenge. This takes a lot of work, a lot of time, and they have been so wonderful and gracious in so many ways. And last, but certainly not least, it's been an honor to be with you. I appreciate the interdisciplinary aspect of this community, but probably most important, thank you for the work that you're doing. It's not easy. Giving people dignity and honor and choices is tremendously important. And I would also like to invite you, if you ever have time, to come on to some of the end-of-life tweet chats, if that's possible. But please stay in touch. I think the conversation will continue to grow. And it looks like we have time for one more question we're going to squeeze in. So we're going to take time for that. This is from Ellen Savelis on Twitter. Can you ask the panelists to comment on the Oregon's Death with Dignity Act?
Well, I'd be happy to take that one. I have been an advocate for that statute since its inception. You know, we stand at a point in time now where we have 15 years of experience with that open practice of aid in dying. It's been closely examined, and what we have found is that it provides an important choice for patients who find themselves trapped in unbearable suffering. It actually raises the floor for improving end-of-life care for all patients, because when that choice is on the table, physicians try harder to treat pain and other symptoms. They make more referrals to hospice and earlier, as I mentioned. And so it's actually raised the floor for all patients, and for the relatively small number that choose it, it's a compassionate option that they're really relieved and comforted to have. And that's why, you know, the state of Washington next door adopted it. Montana has an open practice. Hawaii has an open practice. I'm here in Vermont, where the Senate will vote next week on an open practice. So I think we're moving in the direction of making that choice available.
And Catherine, I think an important point to that too is that two physicians have to be intimately involved in that. It's not just one. So there's lots of checks and balances. Am I correct about that?
Tremendous safeguards in that statute, and it's been so closely examined. The American Public Health Association looked at the data and the practice and said, this is an important option. It poses no risks. It provides benefits. Let's make this more widely available. So I think we'll see that happen.
Lisa, if I could just add one thought. Perspective is important, and it's great to have a panel with diversity. Compassionate Choices, of course, is the former Hemlock Society, so a primary goal is to legalize assisted suicide. But I think as we go forward in our effort to promote good end-of-life care, the focus really has to be on providing the best possible, excellent care for those who are sick. And, you know, I find myself agreeing with Vicki Kennedy, who, when this came up for a vote in Massachusetts, said that giving people a legal dose, a prescription of poison pills in their medicine cabinet, would turn her husband, Senator Ted Kennedy's vision for good end-of-life care for all on its head. So I think as we look forward to a message that can pull us together as an effort to promote good end-of-life care, the focus really it should be on the best possible care for the patient.
Well, and empowering patients with choices.
Absolutely.
Okay. And Ellen said thank you for taking your question. And, you know, as a way of ending, too, this is what I heard a lot from choice seemed to be the whole focus of this whole conversation. The choice of the patients, the choice of the family. And so I thought you all did a wonderful job of bringing up many of the choices, because one size does not fit all at the end of life. And that's an important point, I think, that perhaps all of us could agree on that last point, is that there are lots of choices, and being aware of it and taking care of this and not having the Scarlett O'Hara conversation is important. So once again, thank you so much. I look forward, hopefully, to be in touch with you, as I'm sure a lot of other people are now aware of the work that you're doing. So once again, thank you so much.
Thank you, Lisa.
Thank
A pleasure to participate.
Thank you.
Thank you.
Thank you.